In this lesson, we're going to be talking about the autonomic nervous system and several related topics. This video in particular is extremely high yield in this series because a very large percentage of questions that will show up specifically on the OMM part of COMLEX will come directly from this topic. I'll touch more on this again when we get to the individual topics that are very highly represented. But before I even begin, I just want to alert you to that so that you pay special attention as this video moves forward. The first topic that we're going to talk about in this video is pain fibers. There are two broad categories of pain fibers that transmit pain and temperature signals. The first is the A delta fiber. The A delta fiber is a fast, myelinated, larger diameter pain and temperature fiber. We can compare this to the second fiber, which is the C fiber. The C fiber is slower, it's unmyelinated, and it tends to have a much smaller diameter. So these two types of fibers, the A delta fiber and the C fiber, again, are pain or temperature fibers that transmit signals in the body. The way that you can remember some of the characteristics of these is to use my mnemonic fast, with paying special attention to the A in fast, and slow, and having the word slow begin with C instead of S. So fast and slow for A delta and C fibers. Now we need to talk about a related topic, sensory receptors. Unfortunately, this is kind of a bear of a topic to memorize, and there's no great way to memorize the four main types of sensory receptors, but I do have a few mnemonics which I will give you after we go through this table. But the four types of sensory receptors that you primarily need to know are Meissner corpuscles, Pacinian corpuscles, Ruffini corpuscles, and Merkel discs. So we're talking about three different types of corpuscles and a disc. Let's start with the first two, the Meissner corpuscle and the Pacinian corpuscle. So both of these are large myelinated corpuscles or sensory receptors that adapt very quickly. So in terms of what type of sensory receptor these are, they're identical. So it makes it a little bit easier to memorize. The one that's closest to this is the Merkel disc. The Merkel disc is large and myelinated, just like Meissner and Pacinian corpuscles, but the only difference is that the Merkel disc adapts slowly. So the speed by which it adapts is the only thing that differentiates it from the Meissner and Pacinian corpuscles. Last but not least, we have the Ruffini corpuscle, which is actually a dendritic ending, and it adapts slowly. Okay, so tough to memorize this, I understand, but nonetheless important to know. Now let's talk about the location of each of these four types of sensory receptors. Meissner corpuscles are found on hairless skin, and Pacinian corpuscles are found on deep skin, joints, and ligaments. As far as function is concerned, the Meissner corpuscle is responsible for fine and light touch, as well as position. The Pacinian corpuscle is responsible for vibration and pressure sensation. For the Ruffini corpuscle, this is found on fingertips and joints, and its chief function is to detect surface slippage. And what that means is basically when an object is passing along, let's say the surface of your fingertips, sensing that that object might be slipping as you're holding that object, that's what the Ruffini corpuscle does. The Ruffini corpuscle additionally can detect joint angle changes. The Merkel disc is located on fingertips and superficial skin, and the Merkel disc functions primarily to detect deep static touch, which is another way of saying differentiation of shapes. It also detects position. Now you know what you're thinking. You're looking at this table. There's a lot of stuff that kind of sounds alike, but it's kind of different, and you're not sure what's important. And frankly, this isn't a hugely high yield topic, but it does show up because there are these nuances to this that are very easy for test writers to ask you. But with that said, I do have a few mnemonics which will help shore up some of this chart. So if you're feeling cramped for brain space, let me offer you some sweet mnemonics. Merkel disc is really easy to remember because it has the word disc in its name. And of course, disc is a shape. So it's easy to remember that the Merkel disc is responsible for deep static touch, which again is another way of saying that it helps differentiate shapes. So the only sensory receptor with a shape in its name, which is Merkel Disc, is responsible for figuring out what shape you're touching. For Ruffini corpuscle, instead of saying Ruffini corpuscle, I say Ruffini corpuscle, which reminds me of the rough nature of your fingertips after you get your fingertips wet. And this is a really cool mnemonic because it helps me remember that Ruffini corpuscles are found in the fingertips, and the mnemonic kind of makes use visually of your fingertips being all rough or Ruffini. And Ruffini corpuscles are, again, responsible for detecting object slippage. So if you have your hand wet and then it looks all pruny like this, you might have an object slip out of your hands. So that's my mnemonic for Ruffini or Ruffini corpuscles, for the rough fingertips that may be wet and cause object slippage. For Pacinian corpuscles, I think about the Pacific Ocean, so I call this the Pacific corpuscle. And that's really useful for my mnemonic because it reminds me of a couple things. One is that the Pacinian corpuscle is responsible for pressure sensation, and I think about water pressure in the Pacific Ocean. The second is that Pacinian corpuscles are found in the deep skin as opposed to superficial skin. And because of that, I think about you being deep in the water. And when you're deep in the Pacific Ocean water, you feel that increased water pressure. So deep skin, pressure, it just all ties beautifully together in this mnemonic for Pacinian corpuscle, which again, the PACI, I think of the Pacific Ocean. But again, this table of the 4 sensory receptors, it is important to know. It is annoying to learn and to memorize, but you will be better off if you memorize this. I'm not going to put it in red because it's not incredibly high yield, but nonetheless, it's important. Now let's talk about facilitation. Facilitation is a very important topic. This is very high yield. Facilitation refers to a highly excitable spinal segment, which is marked by 3 important characteristics. The first is that the excitable spinal segment will require less afferent stimulation in order to stimulate that nerve or that spinal segment. The second characteristic of a facilitated segment is that that segment will have a higher resting membrane potential. And the third and final characteristic is that that segment will exist in a hyperexcitable neural state. So the conclusion here is that with all 3 of these characteristics, a facilitated segment or a facilitated body part coming from that segment or a muscle that's innervated by a facilitated segment will exist in a hyperexcitable state with a higher resting membrane potential where less stimulation is required to stimulate it, which basically means that any little action will set off this reflex. That's facilitation. Now, one of the important things that goes along with facilitation are 3 terms that have to do with abnormal reflexes or abnormal pain responses due to abnormal reflexes. The first term is allodynia. Allodynia, it refers to a non-painful stimulus evoking a painful response. So an example would be that, let's say you're getting a flu shot and they rub your arm with an alcohol wipe. Obviously, the alcohol swab is not painful, but if that alcohol swab on your arm evokes an actual pain response where you feel pain in the arm, that's allodynia. The next term is hyperalgesia. Hyperalgesia refers to pain out of proportion to an actual painful stimulus. So let's say that you are watching your 3-year-old niece, nephew, cousin, and that little person in your family pinches your arm. Normally, yeah, a pinch is a painful stimulus technically, but it's not supposed to hurt a lot. But let's say that you get pinched by your baby cousin or whatever, and all of a sudden you feel crazy 10 out of 10 sharp shooting pain in your arm, and it's awful, and you just absolutely start crying. That's hyperalgesia. So you are experiencing the painful stimulus, but the response and the reflex is very much out of proportion to the stimulus. The third and final term that's related to the concept of facilitation is hyperpathia. Hyperpathia refers to when a greater stimulus is required to evoke a response, and then once that response is evoked, the response goes to maximum intensity. So it would an example would be if somebody was poking you with, let's say, a pencil or a pen, and you didn't feel anything, and they're poking and poking and poking, and then all of a sudden, after poking you 10 times, the response that you feel, that pain reflex, goes to maximum intensity, and then you feel 10 out of 10 pain. So as you can see in this example, it took a while for you to have a response at all. But once you did, it went to maximum intensity right away. That's hyperpathia. These three terms, allodynia, hyperalgesia, and hyperpathia, are closely related to facilitation and are particularly high yield. Now let's talk about another concept related to facilitation, and that's referred pain. Referred pain refers to when pain in one area of the body is actually caused by a different area that happens to be neurally connected. This is what's responsible for the somatic pain in the upper chest, jaw, and arm that somebody feels if they're having a myocardial infarction. Facilitation occurs because visceral afferent sensory fibers arrive at the same spinal segments that actually give rise to preganglionic sympathetic somatic nerves. And I know that that was a mouthful, so let me give you an example. Let's talk about somebody who's having a myocardial infarction. Sensory afferents from the heart arrive at the spinal segments that run from T1 to T4. But the interesting thing about T1 to T4 is that sympathetic preganglionic somatic nerves that go from T1 to T4 to the chest and to the arm come from T1 to T4 as well. And what happens is that the brain is sensing both of the sensory afferents as well as some feedback from sympathetic preganglionic somatics that are going to the same spinal segments. And what happens is you sort of get this crosstalk, and the brain experiences somatic pain that's due to a visceral cause. So it's interesting because the sensation of the pain only feels like pain in the somatic distribution, and we don't necessarily know that that pain is coming from a visceral origin. So let's say that somebody is having atypical chest pain, and that chest pain is because they're having a myocardial infarction. If their only symptom is that they have a little bit of pain in the left shoulder that may or may not go down the arm, that may or may not radiate up the jaw, they're not going to turn to you and say, wow, there's something wrong with my heart. They're going to say, wow, I'm having discomfort in my shoulder. So again, it's that somatic distribution of pain that the brain is sensing, even though the origin and the etiology of that sympathetic somatic problem is coming from viscera. So that is referred pain. And what you get from referred pain is this predictable pattern of pain or discomfort, which can be present all over the body and is felt in a somatic distribution, but again, it's actually due to visceral causes. And it's this type of predictable pain pattern that is not only high yield on COMLEX, but is the reason that if you are working in an emergency department and a patient walks in complaining of pain in a certain quadrant or a certain area, your brain starts to move a little bit and think, is this just a muscle pull in that area, or is this a visceral problem that I need to go investigate? Very high yield, very important to know. Now let's transition our discussion and talk about reflexes. This is beginning the very, very, very high yield and important part of the video that I alluded to back at the start of this video. The first type of reflex, and there's four that we're going to talk about, but the first one, and the clearly, without a doubt, the most important, is the viscerosomatic reflex. A viscerosomatic reflex is when visceral pathology causes a somatic response. So the example is what we just talked about. Somebody's having a myocardial infarction, and they're getting left-sided jaw and arm pain as a result. So the etiology is visceral, right? The problem's in the heart, but the response is somatic. The pain is in the arm. That's a viscerosomatic reflex. And we'll talk much more about viscerosomatic reflexes coming up. The next type of reflex is a visceral reflex. And as the name implies here, it's visceral pathology causing a visceral response. So an example would be gastric distension causing increased lower intestine motility. So let's say that you have a huge meal and all of a sudden after that meal is wrapping up or shortly finished, you feel like you have to go have a bowel movement. The reason is because you had a huge meal, there was gastric distension, and a visceral reflex occurred where your stomach told your intestines, hey, it's time to make some room for this new meal that I just swallowed, and go evacuate your bowels. That's visceral reflexes. The next reflex is somatovisceral. As the name implies, it's somatic pathology causing a visceral response. So an example here would be if you have some type of musculoskeletal injury in the distribution of T1 to T5, it can worsen COPD. So someone with COPD or someone with asthma, or just generally speaking, someone that has some underlying lung pathology, if they have musculoskeletal or somatic pathology from T1 to T5, it'll worsen their underlying lung condition. The fourth and final type of reflex is the somatosomatic reflex. This is, as the name implies, somatic pathology causing a somatic response. An example here is, let's say you have a torn bicep. The torn bicep will cause pain in the arm. Perhaps this is the most obvious, but nonetheless, it's one of the 4 reflexes that are high yield that you need to know. Now we're going to talk about autonomic levels. And if you anticipated anything in this video, this is what you came for. Autonomic levels are, without question, the most high yield thing on all of COMLEX. On all of it. OMM, roughly speaking, on COMLEX might be about 1 in 5 questions. Maybe a little less, maybe a little more. It's hard to say. But of those 1 in 5 questions, of the 20% of your exam that will be only OMM questions, of that 20%, the greatest majority of questions will come from autonomic levels. So if you're going to take anything out of this video or even anything out of this course, know your autonomic levels. The only way to memorize these are to use a chart. And generally speaking, I don't love charts, but it's the best way to organize this information. And I'm going to talk to you about how I've simplified it so that you don't need to memorize the autonomic levels for every single stinking part of the body. We're not going to do that. This is the dirty method. You're going to have a very simplified and mainstream way of approaching this. So let's get started. The head, neck, heart, and lungs are all T1 to T4. For your convenience, I've separated this because usually head and neck will be, one group and heart and lungs will be the next, but head, neck, heart, and lungs are T1 to T4. The foregut is T5 to T9. I'll explain this better at the end once this table is fully filled out, but we're not going to waste our time saying the stomach is this, the liver is this, the gallbladder is this, the pancreas is this. No. We're going to simplify. Everything in the foregut is from T5 to T9, and I'll explain that better at the end of once this is all filled out. The midgut is T10 to T11. Again, we're not going to talk about the jejunum is this, the ileus is this. No. I don't want you to get overwhelmed. Everything in the midgut is T10 to T11. The hindgut, T12 to L2. Again, we're not going to waste our time with the transverse colon is this, the splenic flexure is this, the rectum is this. No. Calm down. Don't get overwhelmed. The hindgut is T12 to L2. Kidney, T10 to T11. Appendix, T12. Upper extremity and lower extremity. So we've got 2 extremities here. First, the upper extremity is T2 to T8, and the lower extremity is T11 to L2. The upper ureter and the gonads are both T10 to T11, and the lower ureter and everything else that could possibly be asked in the GU system besides the gonads, which we've already said is T10 to T11, but everything else and the lower ureter is T12 to L2. Now, why did I organize the table this way? As I told you, and I sort of went through this already, but I'm going to say it again, we're not wasting our time with individual visceral structures in the foregut, the midgut, and the hindgut. When I say that the foregut is T5 to T9, what I'm telling you is that stomach, liver, gallbladder, spleen, and pancreas are going to be somewhere in the range of T5 to T9. And you won't be able to get the question wrong if you know T5 to T9. Because let's say they give you specifically the liver in a practice question, or on your COMLEX for that matter. if they're going to do that, they can't give you two answers that are both in T5 to T9. So what I'm saying is, if in the vignette the question is, they give you hepatitis, let's say. You have identified that it's hepatitis. You know that the problem is the liver. And then the answer choices are different levels. It's not going to be A, T5 to T6, B, T7 to T8. They can't do that because both of those are in T5 to T9. Only one answer choice will be within T5 to T9. So if you memorize that all of the foregut is somewhere between T5 and T9, you'll use the process of elimination to get the answer right. So we're not going to waste time memorizing this minutia, okay? Stomach, liver, gallbladder, spleen, pancreas, all foregut, all T5 to T9. For the midgut, the distal half of the duodenum, the small intestine, the ascending colon, the hepatic flexure, the first 2/3 of the transverse colon, all of that is midgut. All of that is T10 to T11. And then hindgut, same thing. Distal 1/3 of the transverse colon, splenic flexure, descending colon, sigmoid colon, and rectum. All of that is T12 to L2. We're not going to waste our time. We're not going to compromise any of our very limited brain space. We are just going to know that the hindgut is T12 to L2. And then again, on test day, you will use the process of elimination to get the question correct if you get a specific question where you know that it's, let's say, the splenic flexure, and then you have to pick out something from T12 to L2. So a lot easier to do my way than the very silly way of if you crack open some primary literature or maybe one of the OMM review textbooks. I don't know what sources that you like to use, but it tends to be overwhelming and frankly unnecessary. So this table, again, just to really hammer this home with a 3,000-pound hammer made of gold, this is high yield. You have to know this. If you don't memorize this and you don't know these levels, you are going to get a lot of questions wrong. So spend your time here. Before we conclude today's lecture, the last related topic that we need to talk about are the ganglia. So just as a quick refresher, ganglia are cell bodies that have afferent and efferent nerves relaying signals between the body and the central nervous system. And basically the ganglia are putting out both sympathetic and parasympathetic effects on target viscera. So the ganglia determine which signals go out and which signals come in from the viscera, which connects sympathetic effects like the brain telling certain things to do fight or flight, or the brain telling certain viscera to do rest and digest. So again, ganglia, pretty important. But what do you need to know for COMLEX? You need to know the foregut, midgut, and hindgut, what levels correspond to each of those different guts, which we've already talked about in our last discussion on the autonomic levels. And then the very high yield part of this table is that you need to know the sympathetic ganglion and the parasympathetic ganglion responsible for feeding sympathetic or parasympathetic innervation to the target viscera. So let's get started with this brief discussion. The foregut runs from T5 to T9. The sympathetic ganglion responsible for providing sympathetic innervation to all of the viscera in the foregut is the celiac nerve. The parasympathetic ganglion responsible for providing parasympathetic innervation to the viscera in the foregut is the vagus nerve. The midgut runs from T10 to T11. The sympathetic ganglion responsible for sympathetic innervation to the target viscera in the midgut comes from the superior mesenteric nerve, whereas the parasympathetic ganglion comes from the vagus nerve. So the parasympathetic ganglia for both foregut and midgut is both the vagus nerve. Let's talk about the hindgut. The hindgut runs from T12 to L2. The sympathetic ganglion responsible for sympathetic innervation to the viscera in the hindgut comes from the inferior mesenteric nerve. And the parasympathetic ganglion comes from the pelvic splanchnic nerve. So a little tricky because vagus nerve is both parasympathetics for foregut and midgut, and the difference is that the hindgut gets pelvic splanchnic. This chart is very high yield, not quite as high yield as our last discussion on the different autonomic levels, but nonetheless, this is very important in and of itself. So that wraps up the video on autonomics. There's a lot of information, a lot of high yield information. So a lot of things really deserve your attention today. Please pay close attention to this video, review it a couple times if you need to, and know this information well, because this is bound to show up on not only in-class exams, not only in-class practicals, but also on the OMM section of COMLEX.